Alrighty, we are going to go ahead and get started with the beginning portion. I have a few announcements. If you are not receiving emails from pre-health shadowing and you would like to stay updated with the upcoming sessions, there is a couple ways that we can do to fix that. You're going to go into your email and spotlight search pre-health shadowing. You may have to look in your junk or spam folder, as some email companies have been sending our messages because of the number of links that we attach to our emails. And so make sure that you guys are searching into the junk and spam. Go ahead and mark our emails as important. This will just notify the email company that you are wanting to receive these emails. Another thing you can do is save pre-health shadowing as a contact. And this will allow your emails to bypass the junk and spam and go directly into your inbox so you can get notified in real time of our upcoming sessions. Not only do we send upcoming sessions, but we also have exclusive opportunities for pre-health shadowing students. This might be discounts, it might be specific workshop opportunities that are only available to our student body. And so be sure that you guys are subscribed. A next update is that we now have closed captioning for all of our sessions, and I'm going to be sure that that is activated. I apologize. Okay, I will be sure that this is activated once my screen share is stopped. Another announcement is our website has been having a lot of errors recently, and this is due to the recent influx of students. We have gained lots of students, and we're really excited that you guys are all joining us on our journey to get these virtual shadowing hours. But we ask you to please help us keep our program alive. This is a free program in order to keep our mission goal of being accessible and flexible for all students. It is flexible because all of our sessions are recorded and posted to both our website and YouTube channel at a later time so that students can review it if they had any conflicts. And it is accessible as this is a completely free program for anyone who is interested in joining. So please share this link. Please try to donate if you can. $1, $5, anything will make a difference. And we appreciate anything you guys can provide. Another announcement, if you guys are attending our live session today, I welcome you to tag at pre-health shadowing, either a picture or a video of you participating in today's session for the chance to get reposted on the official pre-health shadowing account. Again, really quickly, students can take the post-shadowing assessment to verify their virtual shadowing hours. So I encourage you all to take good notes and ask questions. And without further ado, I would like to welcome to you today a general practitioner from the UK, Dr. Zirva Khan. Welcome.
Need to remember to unmute myself. Hi, thank you very much for having me.
Thank you for joining us today. So this, we're going to start off with what interested you in going into the health field? What was your motivation in going into the health field?
I have one of those really corny stories where, like, when I was 5, I really wanted to be a doctor and I never thought about anything else. So I think I was really little and I went on holiday and I got really poorly. And because we were staying with family, my auntie looked after us really well. I think she was a medical student at the time. So I thought, like, I want to be like her. That was the initial motivation. But as I grew older, I pretty much had no other focus of what I wanted to do, which I don't think is a good thing. I think it's good to always explore all your options, but that's literally the path that I took. So at every single level, I was like, well, I need to get the grades because I need to get into medicine. I need to get the grades because I need to get into medicine. And that's it, really. And I was lucky that when I did apply, I got an interview and I got an offer. So it all worked out in the end.
Thank you. Can you talk about your education leading up to becoming a doctor?
Sure. So our journey in the UK is very different to the journey in the US. So obviously I can only talk about my own personal experience, but the way that it works over here is you have like, I think, so we've got our GCSEs, which are the exams you take when you're about 16. And they're sort of the mandatory education level of the country. So you need to do really well in those exams. They include kind of compulsory stuff like sciences, English, maths, and then lots of non-compulsory other stuff as well. I actually went to an art school. Again, I don't know why, I think it was just the area that I lived in. So I had to get kind of at least A's. The highest grade was an A star. So I had to get at least A's across most of my subjects. And I was fortunate that I managed that. And then the level after that, which is A levels. So we do our A level exams when we're 18, and that's kind of like our pre-university. So we would do A levels, and then we would start an undergraduate course. So for my A levels, I then took the sciences, so maths, English, no, not maths, English, maths, physics, biology, and chemistry. In the UK, chemistry is pretty much compulsory unless you do something like a foundation course, which is like an extra year at university before you do medicine. And again, they want top grades for that, but they want a lot of other things as well. And I genuinely was interested in medicine beyond just, you know, getting the grades and getting a place. So we had to do voluntary work. I used to volunteer with a summer camp where children would go for like 1 or 2 weeks, and we would just basically arrange activities and do that with them. So I've always really enjoyed education as well, and that's something that I have explored and developed on since I've become a doctor. So we had to do that, and then I did obviously do some voluntary work with disabled children, blind children, did some hospital work experience as well, where I was in an elderly care ward. Yeah, and then over here we can only apply to 4 medical schools. You can apply to 6 universities as a whole, but for medicine or dentistry or veterinary science, you can only apply for 4. So I had an interview from one place, and I got an offer from one place, and then I just had to make sure I got the grade requirements, and that's it really.
Thank you so much for that. Would you be able to go over a little bit about your process with admissions into university with us?
Sure. So the admissions process over here, we in school, so when we're doing our A levels, our tutors need to submit estimated grades. So that's one part of the criteria. The second part of the criteria is that you've generally got good standing, a good rapport with the school. Then you have to write something called a personal statement, which is essentially, it's your chance to sell yourself and make yourself kind of look like, yeah, I'm someone who would be worthwhile doing medicine on your course. Since I applied, there's been lots of other changes now. So there's at least one exam that a lot of students have to do, and they need to do quite well in it. Certain universities require a second exam as well. So that's generally the kind of interview process. Then if you get an interview, you obviously have to come to the interview. Over here, interviews again have changed a lot since I applied. So my interview was a panel interview, panel style interview. So I was in like a little room with 2 people. One person was asking me one question, the other person was asking me the second question, and it was like that for about 15-20 minutes. Whereas now it's quite different. It's more of like, I think in the US you guys might call it a viva. So you go around in stations, you know, they can be 10, 12 stations. Each station has a different element that they're trying to assess. So it can be communication skills, it can be empathy, it can be how you would manage a situation when you don't know what to do. So, you know, how you keep yourself cool and things. But as you can imagine, because of coronavirus, all of that has changed a lot. So from what I've heard anyway, most universities over here are doing it all virtually. So they have actually got a setup where they're either going to do a panel interview online, or they'll be doing the similar kind of Viva style as well. And then obviously, depending on how you do in your exam, in your interview, you'll then you know, either get offered a place, and if you've done really, really well, they might say, we don't care what grades you get, we want you. So that's an unconditional offer. They might say, actually, we really like you, but we still need you to get your grades, in which case, obviously, if you get your grades, then they'll accept you. In other instances, they say, okay, we really like you, but we want you to do better than the grades that you've been estimated. So it's very variable depending on what they feel of you. With me, I was quite lucky. They just, and this is like, so I applied, when was it, 2006, so it's a while ago now. But when I applied, they didn't really have as much of a structure. So I literally, I had my interview on a Tuesday and I had my offer by Friday, which that's really quick. Normally people are waiting, you know, 2 or 3 months for an offer. So I was really blessed because I only actually, out of the 4 places I applied, I only got like one interview, and that was the one place that I got the offer from. So importantly, as long as you get an interview, you know, and no, it doesn't matter where it's from. For me, that's how much I wanted to do medicine. So I was really fortunate that it worked out how it did.
Thank you for that. The next question is, why did you decide to go to general practitioner route?
So when I was studying in medical school, if you would have asked me then, I hated family medicine. I despised it. In all the clinics that I sat in, I really didn't enjoy it. So it was never something I wanted to do in medical school. In medical school, I really liked fast-paced medicine. So, you know, A&E, you know, like the ER, I think you guys call it over there. Over here, like acute medicine as well. So, you know, people come in really sick, you do something really simple for them, and they become really they become better really quickly. That was always what I wanted to do. So even when I started, so when I qualified as a doctor, that was still my plan. And I started working in hospital and I really enjoyed it. But when it came to the year where I was applying for my specialty training jobs, because we did 2 years as like a house officer and a senior house officer, and then we apply into a specialty that we're interested in. So literally, I think up till about 4 months before my application, I was still dead set on doing acute medicine. And then I did an ER job as an SHO, and I enjoyed the work. I didn't even mind the shifts, but I basically had a really bad experience. I had pretty bad supervision. I think to some extent I was bullied as well. And it really, I don't know what it's like again in the US, but in the UK, the hospital's gate, you can say, is the emergency room. So, you know, the whole of the hospital management system literally operates from there. What happens in there depicts what's happening in the rest of the hospital, and kind of vice versa. So I really didn't like it, and I thought I can't really imagine myself living like this, you know. And also, like, you know, I found someone and my life choices were changing a little bit as well. And I was like, I really can't see myself doing this kind of a job. Like, I'm not going to find satisfaction doing something like this. But I still really did not want to do family medicine, even though everyone kept on saying to me, yeah, it's going to be the best one for you. And I'm like, no, I don't want someone else to make that decision for me. That's a decision that I need to make for myself. So I was really lucky when I finished that ER job. I actually did have like a general practice job as well. And the things that I thought I'd hate, I actually really enjoyed. So the stuff that I was always very dismissive of, particularly, which I'm obviously really embarrassed to say now, but was like mental health, because I just didn't get it. There's a lot of mental health, people coming with like what I thought were very minor problems, but I think I just had a very superficial approach of it when I was a medical student, and suddenly I just saw it in a different light. And then obviously one of the other benefits that I saw when I had this kind of taster job was continuity. So like you'd you know, meet someone and then you get to know their family, and then you'd see how they're doing afterwards. I mean, well, that was one of the things in acute medicine and the ER, like you'd see somebody once and then you'd probably never see them again. You never know what actually happened with the treatment that you gave them. Did they get better? Did they die? Anything. So in the end, that's the kind of route that I went for, and I'm really glad I went for it as well, because it's incredibly flexible in the UK. So we don't have to just be like family doctors. We can do other things on the side as well. So, you know, during my training, I also did some extra qualifications. So being a female GP, I know most of my consultations in the UK anyway will be surrounding women's health, sexual health, teaching as well, because I'll have students coming and trying to learn and things. So I got extra qualifications in those things, and you know, I'll be a doctor till I'm probably in my mid 60s, so I've got lots of time to kind of build upon that if I want to. But I've got a small family now, so it's suiting my lifestyle well as well.
Perfect. Thank you so much for sharing that with us. It's very, it's great to hear about how you chose, because I know a lot of us younger students are still in that process. And a question that we had in the chat is, can making connections with patients become difficult? And extending on from that, do you have any examples of this, and how do you distance yourself if and when needed from patients?
So good question. I think most patients are very aware of like the patient-doctor relationship, so they know it's a professional relationship. You know, you have to keep your professional boundaries as well. When they come and see you, you are their doctor and they are your patient. So there are some kind of codes of conduct, you can say. So, you know, you're not supposed to treat a family member, you're not supposed to treat a friend, these sorts of things. So nearly everyone that you see is kind of like a stranger for you. But I think naturally, and there's definitely nothing to be embarrassed about with this. This is probably something that I didn't really understand before, but I think the more time I've worked, it's something that I have just normalized. So, you know, we are human as well. You know, there will be some people that we actually really get on with and really, you know, really like them. You know, obviously in a professional manner, but you really like them. There's just some people that you meet in the world that are really nice, and they're, you know, they you feel for them, the way that they live, and the troubles and the hardships that they've been through. And you know, when bad things happen to them, you do feel sad. But again, you know, once you're very firm and confident in your role as a patient and as a doctor, then there aren't really any like, it's not really that difficult. You know, there are some times when patients will behave a little bit inappropriately. They try and get a bit more frank. They come up to you and they kind of call you pet names and stuff. And you're like, okay, you know, I'm Dr. Khan here, so you know, let's get back to the matter here. There are some people who can take it a bit further, in which case, you know, if they don't understand the rules, which you have to make very explicit, then you know, it's completely within your rights to say, look, I don't feel comfortable seeing this patient, but I will arrange for them to see somebody else. And that has happened, not necessarily to myself, but it has happened to other colleagues.
The next question that we have is, can you talk about your day in the life as a doctor? Like a
Sure.
regular day?
Yeah, no problem. So my day has changed a lot since coronavirus has started. So I'll explain to you like what my day was like before, and then what it's like now. So normally my surgery starts at 9 o'clock in the morning. I'm a salaried, so I've got a salaried post. It means that I'm not like a business owner. I don't have my own practice, but I practice within a company, within like a surgery setup. So my clinic starts at, my morning clinic before coronavirus used to start at 9 o'clock. So I try and get there a little bit earlier, sort out any kind of urgent admin that needed to be sorted out on the day before I start my clinic, so that my mind is clear. And then I started my clinic. Now, again, before coronavirus, everything was face-to-face. So you'd have a waiting room outside, patients would be waiting in there, you'd call them in, you'd see them. We have 10 minutes usually to do a consultation. And then once we're finished, then they go. So in the morning, I probably would have had about 13 or 14 face-to-face consultations, and then I'd have 2 or 3 telephone consultations, which were normally kind of easy things where the patient didn't necessarily need to come, or they were working, and it was just much easier for them to answer the phone when they were at work. So, you know, following up of blood tests, or following up of symptoms, or doing like a medication review on the phone. Then we used to have like 3 hours where we would have admin to do. So these are letters that came from the hospital, letters from other specialists, requests by the patient, including like medication requests and things, and obviously any home visits that have been requested. So in the UK, I don't know again about the US, but here we do home visits. So if there's a housebound patient, then we will go out and see them and assess them and things. Generally, it's just, the aim is so that they would be able to stay at home and be treated at home. But sometimes if they're really sick, which is why we take some equipment with us to check, they might need to be admitted into the hospital. So that's what would happen over the kind of lunchtime period, and obviously try and eat something and have a bit of like a half an hour breather. And then the afternoon would be sort of like a 2 or 3 hour clinic, again, mainly face-to-face with like 2 or 3 telephone consultations at the end, and then just winding up. So making sure that you've done all your admin, there's nothing outstanding. And because I don't work every single day, that's even more important for me, that I've not got anything urgent outstanding for the days that I'm off, because I won't be able to do my admin on the days that I'm not in. The main change that's come because of coronavirus is we have essentially, majority of our consultations are now either telephone or video. So most of our clinic is that. And then if there's anyone that we assess on a telephone or video who we feel needs to be seen face to face, because otherwise we can't do an assessment of them, or we can't really figure out exactly what's going on, then we would arrange a suitable time to bring them in a kind of a safe place to be able to assess them with all the right PPE and everything like that. So that's our typical day. Coronavirus has made our typical day much busier. So I don't always have a chance to like have the break that I'd like, or I don't always get my admin done, which is a pain, because it's just extra work for the next day that you come in. But I think from what I've heard, especially with other kind of GPs in the area, I think this is just generally a problem because of coronavirus. So I hope that helps.
Definitely. And then you touched on this a little bit, but another question we had is, what is one of the biggest challenges in your day-to-day as a general practitioner?
So I think one of my biggest challenges is, I think generally speaking, so in our general practitioner job, in the UK anyway, we don't really have many facilities of investigations. So we really have to rely upon our own clinical kind of knowledge. So, we can do blood tests, but they might not be checked for like 3 days. So you would only organize tests that you are happy to wait for the results of. And I think that's sometimes the difficulty that I find is, sometimes it'd just be nice to do like an urgent test right in front of me, and I've got the result and I can talk to them about it like you would in hospital, but we don't always have that. And I suppose with coronavirus, it's become even more kind of difficult because, usually when you've got someone in front of you, you get a really good idea, okay, this person is sick, like I know exactly what I need to do here. But when you're speaking to someone on the phone, you can't see them. So you don't always know that what you're hearing is actually what you're seeing, and it is what it is. So that kind of risk management can become quite difficult, but we've been doing it now for like 6 months, this kind of changed way of communication. So I think we've gotten used to it now.
Thank you for sharing. The next question that we have is, what was the most challenging part of medical school for you?
Good question. With medical school, so I think this kind of varies depending on which medical school you go to. So with my medical school, I don't know why, but they never really openly told us what our curriculum was. So we didn't know what depth to learn what in. So, were we supposed to learn things right to the mini cellular, to the stuff that I don't know, is it even relevant with being a doctor, of like a general speciality? And another thing that I found really difficult in medical school, in the beginning more so rather than kind of in the later stages, was when I was studying my GCSEs or my A-levels, we had a lot of support from the teachers. So the teachers would like sit down with you, go through questions, and be able to answer any queries that you had. And it always felt like it was more of like you had a bit of a mentor with you as well. Whereas when you go into medical school, it's very much like on you, what you learn, how much you learn, how you learn. They just tell you this is what you have to learn, and how you do it is up to you. So you do have to grow up quite quickly. I think that was something that I struggled with in the beginning. But like I said, once you get used to it, and you realize actually what I'm doing is fine, then it's okay, then you've got the confidence in yourself.
Thank you so much. And then another question that we had is, can you or do you have your own practice, work in a clinic or in a hospital? And how did you decide what to do?
So I work in a clinic, and in this clinic there's about, so it's a difficult setup to try and explain, but it's like a mini corporate clinic setup. So you have clinics across the town, but because obviously we're virtual, there might be like one doctor sat in one of these clinics dotted all around the town. The reason why I went for this is because I only qualified as a GP just under 2 years ago, and I've got a young child. I feel like I'm quite early on in my career. Like I don't think I know enough to kind of set up my own. Over here it would be being a partner, which is like you're kind of a business shareholder of a company, and that clinic is yours. So you would see patients as well, but you would also employ other people. So I don't feel like I'm quite there with it. And I just thought that the structure of being a salary doctor, so, I'm employed, I have sick leave, I have annual leave, I have maternity leave, all of that is covered as part of my package. So what I was getting as part of my deal for me was just working out better in terms of the kind of work-life balance thing. But I do think when I don't know how long it will take, but I do see myself in the future, hopefully, becoming a business shareholder and, being a partner as part of a company, and seeing how it goes.
Thank you. You briefly went over it, but can you talk about why women's health and mental health are your main interests to work with?
So women's health, when I was doing my general practitioner training, it just happened to be coincidentally the two jobs I did were like kind of obs and gynae, and I also did a job in sexual health. So I think without trying to I'd already developed a lot of knowledge in those particular areas, and obviously being female as well, most females want to see like a female doctor. So it was just something I knew I had to be good at. Mental health has become a bit more of an interest, I think, since I've seen how badly it's done, and I've seen how, especially with kind of really soft communication skills, kind of listening skills and things, a lot of mental health problems can just be managed at the first consultation. And I am from a South Asian background as well. I'm kind of born and brought up in the West, but it's another thing that I've realized mental health isn't really managed that well in South Asian backgrounds, and minority, black and minority backgrounds as well. So that's the kind of reason why I suppose those interests have developed, to be honest.
Thank you so much. Another question that we had is, have you ever known anyone who moved from the US to the UK to work after medical school, or vice versa? And then can you talk a little bit about the differences and what that transition can be like?
So I don't know too much about the actual kind of ins and outs of the process, but there are lots of resources online, and perhaps you guys have contacts and things. But I know someone who studied, I don't know if this counts quite, but Trinidad and Tobago, does that come under like US area-ish? It's outside of the US, but he studied there and then he came across here. So he did do the USMLE, but I don't think the score was great. So he then did the PLAB exam, which is the main exam people do to come across here, unless they've done like further training. So, if you become a consultant or something, then you don't necessarily have to do PLAB to come here. Some people, when they come from other countries, they then have to, show like their English competence and stuff. But I think if English is part of your kind of school curriculum and things, that's usually sufficient. And then when they come here, I think kind of the beginning stages are pretty much just trying to understand how the NHS works, because our healthcare system is incredibly different to everywhere else in the world. So we are government funded, tax funded, so free at the point of need. Most things are provided on the NHS free. Emergency care is free, and there's a lot of kind of routine minor stuff that won't be covered by the NHS, and things like that. So I think they just need a little bit of time to settle in, get a bit of experience. And then depending on the stage of their career that they've come across on, depends on kind of what post they would next take. There's a lot of people that come from the US and settle in like the bigger cities, because I think they're just better equipped to deal with people from abroad. But then that doesn't mean that kind of smaller areas haven't, you know, I don't live in a big city at all, but we've had people from all over the world come and work in our hospitals over here. So the training system across the country is the same. It's like a national, it's very similar. If you come at the start of your career, then I would always encourage people to join onto the foundation program, which is, you know, like the house officer, kind of senior house officer level, so straight after medical school. And because that's your easy way to kind of learn the system, and then kind of ascend through the levels to get to whichever training program you want to go down and things. I know a few people that have gone across to the US, some by choice, some it's because, you know, they found someone who's from the US and they you know, they didn't want to move from there and they decided to move across. There are a few people on Instagram that do work in the US and they've gone from here. So again, I don't know about contacts and things. I don't really want to kind of say anyone's name here unless I'm not supposed to. So, you know, I'll leave that for you guys, unless you want me to kind of mention any particular names I know off the top of my head. Hope that's helpful.
That's totally fine. You've mentioned that you're South Asian and you're also a woman. Did you ever experience like discrimination in your journey becoming a doctor, and as a doctor as a South Asian woman?
That's a really good question. And I think it's really nice that people are actually talking about it now, because I think for a great amount of time, most women and people from kind of South Asian backgrounds or any kind of minority background, Black backgrounds, ethnic minority backgrounds, have generally been expected to be quite quiet about it. So discrimination wise, I've probably not faced it as much as maybe other female South Asians have. And I think one of the reasons for that is because I do dress in English clothes. So, you know, I probably seem a little bit more acclimatized to the environment and society. I'm not sure if maybe I wore my own kind of national attire and went out, whether I'd faced the same amount of, I don't know, acceptance. So the first time I felt discriminated against, and this is by me just being brown, was when we are doing hospital placements as medical students, and we have to take a history, so, you know, to practice how to take histories and things. So and we're placed with partners, so there was like, I think it was a white male who was my partner, and we went up to take a history, and she instantly said, I don't want a history, I don't want you to be here, I don't want to talk to me, because she never specified exactly why. I want to talk to the Englishman. And I was like, right, okay, you know what, you do realize I can speak English, and I can speak English quite well. And she wasn't having any of it. So I went, and bearing in mind this is like 2008, 2009. I went, obviously I was a bit upset, because I was like, this is really odd. Like, I've never had this happen to me before in medical, like, you know, elements of racism and sexism. Like, I think most women will have had some kind of racism and kind of sexism throughout their lives. But I never thought it would be when I am a medical student or when I'd be a doctor. But anyway, I went and I spoke to like who our supervisor was, and I said, you know, I explained the situation, and they said, and at the time, because I was so junior in my medical school kind of career, it felt really uncomfortable what they said, but I accepted it. I didn't argue it. And they basically said to me that it's the patient's choice. So if the patient doesn't want to see you, doesn't matter on what grounds, they don't have to see you, they don't have to speak to you, but they have a right of care. And I was like, I'm sure that's not right. Like, you know, if someone's being discriminatory or being sexist or racist, surely that's like, you know, there's a zero tolerance for this. And I was fortunate I never had any experiences of the sort after. I think even kind of sexism experiences were, I don't think I really experienced anything as a medical student. I did as a doctor, but there was, when I worked in the sexual health clinic, you'll see some really strange characters, and there was just some pervy guys that would come into the clinic, and they would try and hit on like the young female doctors, and this particular guy was Asian as well, and he tried to make it seem like it was even more acceptable to be trying to hit on like an Asian woman. And I essentially said to him, like, blanket, I was like, this is inappropriate, this is unacceptable, I'm not going to consult with you. And I walked out of the room. You know, he wasn't there for a life-threatening problem, and I passed it on to someone else to see to him. And I think he was given a warning as well about his behavior. So there are definitely policies and measures in place. I would just say it's a shame that it's taken such a long time for there to be any movement with it. And I did later find out after I spoke to some colleagues, and as I've learned a little bit more about equality and diversity, that actually what happened to me in medical school was really bad. Like, that shouldn't have happened. That patient should have been warned and things, but what can you do, I suppose.
I'm so sorry to hear about those instances, and thank you so much for sharing them with us. A kind of question that's a change of pace that a student sent is, sorry, it just disappeared from me, is how did you find the balance between going to school full-time and finding the time to gain patient care experience?
So by school, if you mean like, do you mean medical school? Full-time medical school? Is that, or?
I'm not sure exactly what the student meant, but I feel like that's a good place to go with to start.
Yeah, I can talk about both either way. So medical school, our medical schools here anyway, it's part of the structure. So I don't have to do anything extra. I don't have to kind of do any. I don't have to arrange any extra placements or anything to get that exposure. I suppose, you know, the first couple of years are just mainly theory. So we don't have any patient contact during those times. So you then start to develop your own learning style, and that gives you confidence. And I think once you start having other commitments, like you've got placements and stuff, it just means that the time that you've got, you manage it better. So, you know, I've only got X amount of time and I've got to learn all of this. So what's important for me to learn? What are my priorities? What's not so much of my priority? And I can come back to that at another time. When I was in kind of A levels and school and things, it was just something that I accepted. I had to sacrifice my own personal time. So I might not have been able to see my friends, might not have been able to see my family as much. It does eat into that. And I think throughout medical school as well, you know, thankfully I never missed a wedding. That was always something I never wanted to miss, a wedding or a funeral. But there was lots of other things that I missed. So, you know, I missed people's birthdays, I missed opportunities for going on holidays, and because our term times were much longer as well. But again, I told myself it's only for 5 years. It's only for 5 years, and then once I'm done, that's it. I've got my life back. So yeah, I hope that answers the question.
Thank you for sharing that. The next question that we have in the chat is, when a new patient comes in, what are some questions you ask in order to find out what is wrong with them, or like what's the problem with them?
That's a good question. So with every patient, it's a little bit different. But my style is, and this is how we're kind of taught in our communication skills as well, is start with open questions. So I really try and let the patient kind of direct the conversation in the beginning. So I want the patient to tell me why they've come. And, you know, I give them a platform essentially just to tell me. So, you know, I start off with, how can I help you today? And they usually then mention what the problem is. And if some patients are very chatty, and then you have to try and work hard to try and stop the chattiness, because otherwise it will just go on for about 20-25 minutes, and you know, there's 3 people waiting outside to see you. For other people, they're actually very reserved, and they don't know how to get the kind of their words out, and they don't know how to explain their problem. In which case you then start giving them prompts. Okay, so do you mean here? What do you mean by this? You know, can you clarify that? And I suppose another really important part of my kind of history taking style is listening out for cues. So patients are very good at dropping hints of what really is bothering them about the problem that they've come in with. You might think, oh, you know, they've got a rash, and it's just what they want to know, how to treat the rash, when actually, you know, they might think that this rash is HIV or something. And they will drop these hints in, and until you address those hints, no matter what management plan you give them, until you've addressed that problem, they won't be satisfied with the consultation. So I always try really hard as well to make sure that I've picked up any concerns or expectations of theirs, and try and address those as well, so that they don't feel like they've not been listened to. So that's generally how I would approach anyone who comes into my clinic.
Thank you so much. Another question that we had is, how do you maintain a work-life balance?
Good question. I don't think there's a perfect answer for this. So all I know is on these particular days, I go to work. Sometimes when I go to work, it's not stressful. Sometimes it's really, really stressful. So I need to have things that I do when I come back home or outside of my working days that keep me sane and keep me kind of going, and kind of reminding me of the things that I like about life as well. And I suppose the further I've gone down the line from, medical school and becoming a doctor and then becoming a GP, the life part of it has become so much more important. So when I was like single and I had no other commitments, I was just like a workaholic, you could say. I didn't really care about very much else. I'd kind of work hard and I'd see my friends and have a good time. Whereas now it's like, I have a 3-year-old I'm responsible for, and I have a family, and I have to kind of balance that. So I really, really try on my days off that they're basically kind of work free. So I try and spend as much time with my son, because he's a year away from being in kind of compulsory education 5 days a week. So we try and do some activities together. Before coronavirus, we had a much busier social life. So we'd be seeing family, friends, going on holiday and things. That's obviously changed a lot. So it's meant you have to try and find things, I suppose, in your kind of 4 walls and around you, about, things that keep you going. So I've got a few hobbies, I read, I write a little bit. I've started up my Instagram page, so that's taking up a bit of time of mine as well. And then obviously with family, we have woodlands and things that we go walking in, just little excursions that we do. You don't realize how much those little things matter. They might not sound like very much, but it's just, doing really normal things as well. So that so far is what keeps me going.
Thank you. Did you ever go through imposter syndrome, like feeling you're not good enough to be a doctor, or like you're not good enough to be in med school, something like that?
Yeah. So again, it was more at the beginning of my medical school time. I don't think I really felt it as much as a doctor, because I think when you've been in medical school for so long, when you are a doctor, you're like, oh my God, thank God, I've reached the other side and I'm out of here. But when I was in medical school, especially in the first couple of years, majority of the people in my cohort and in my medical school were from like really well-off backgrounds. So, they were people whose parents paid for their university education, they were paying for their rent. They had their own like new cars, and they were going on kind of really expensive holidays. So there was a time, and especially when I went for my interview as well, because I met some of these people, I did sit and think. I was like, is a person like me really designed to be a medical student? Because, I don't really fit a lot of the tick boxes. But then at the same time, I think the way of thinking that I've always had, which has always overridden all of these imposter syndrome thoughts, is that I really believe representation matters. So I never saw doctors like myself when I was growing up. So I wanted to be the doctor that I couldn't see. And I think if imposter syndrome holds you back, imposter syndrome is not a good thing. But I've always had a mechanism way around it. And that's the thinking that I've always had. So, there weren't that many people from like middle class backgrounds or even kind of working class backgrounds that were in medical school. So it was never something that I felt guilty about, because I thought, look, if I can get through it, then at least I can go back to my old schools and show them that someone like them can also become a doctor tomorrow. So yeah, a bit of an emotional story, but that's kind of always been my approach with it.
Thank you so much. I feel like that is an amazing approach to it. Another question that we had is, can undergraduates from the US attend medical school in the UK?
Yes, so I'm pretty sure you guys can apply directly if you wanted to. You would be coming across here as like an international student. So the fees are extortionate compared to like the fees. So as a rough example, a home student would be paying £9,000 a year. I think that's about $13,000 or something. I don't know how much education is over there, but for us, that's quite a lot as a home student. And depending on which country you come from, then your university fees are like either double or triple that. So it's quite a lot of money. And then obviously you have to think about if there are any. I don't think there's any. I'm not sure about visa stuff, but there are some other costs about relocating yourself and everything like that. Was that the question? Was there any more to that question? Sorry.
No, that was perfect. Thank you so much.
Okay.
The next question we had is, would you please touch on the different rotations that you had to do during med school and what were they like?
So the aim of medical school really is to like give you exposure to everything. So they spend more time with you trying to get experience in, the health problems that are more common, and then you probably have a little bit less experience in the health problems that are less common. So, my main shadowing experiences were like urology, general surgery, colorectal surgery, upper GI, gastro, the main systems in the body generally. So neurology as well. Things that I had, obs and gynae, pediatrics, obviously those things are really important. I did have a bit of psychiatry, but the psychiatry exposure we had was very specialist psychiatry. So I felt like it wasn't ever psychiatry that I would see as like a GP, but then I also had a lot of general practice experience as well, which is obviously where my preconceived ideas of me hating it came from. Things that I got a lot less exposure in was things like sexual health and ENT, which I was actually really disappointed about, because I think if I'd known more about sexual health as a medical student, I may have pursued a career in that. But then again, this is what's great about family medicine, that I can incorporate that in my career anyway. So that's generally the gist of it. There were some students that were very much like, I want to be a brain surgeon when I finished medical school. That they were very set on what they wanted to do. We had special study modules, and they could essentially choose to do extra projects and extra research, and even maybe take a year out and do a master's, another kind of qualification in the field of interest, you can say. But because I had a very general interest anyway, so I didn't do anything extra. I just tried to do what I wanted to know about.
Going off of that, you talked about how family medicine wasn't your favorite during your rotation. What was your favorite rotation?
My favorite rotation, I think, was acute medicine in the end. So I really liked neurology first, but then I realized that most people with neurology problems will die. And I thought that just make me feel really sad. Like I couldn't dealing with a lot of death and things. And then I thought acute medicine, I was like, oh yeah, I literally went in one day to a ward and there was like 10 people, and the next day I'd come back and they'd all gone home, or they'd all like, gotten better. And I was like, wow, this is awesome. Like you just do like really simple things, really common sense intervention, and they just get better and go home. I was like, this is quite nice. No one's dying here. Like you'd get a death rarely. So that was probably more of my favorite rotation.
Thank you. Our next question is a two-parter. And so it's, how did the NHS respond to the COVID pandemic? And then in your opinion, what did they do well and what needs to be improved?
Okay, so politics. So the way the NHS responded was, it's difficult to kind of summarize it all, because there's been just literally an overhaul in the way the NHS works. So, from general practice, like for example, we completely changed the way that we were consulting. So we were still open, even though there was lots of rumors in the newspapers and things that GPs weren't seeing anybody and we're not talking to anybody and they're closed, shut. It wasn't like that at all. We were still consulting with patients. we just took on technology, which, to be honest, the NHS, I will always say, is very behind when it comes to technology, but that's a story for another day. So we embraced technology to be able to try and provide the services we could to patients the best that we could. There were lots of issues in the way that kind of the NHS had to handle. So one of the problems was that, as you've seen in the US as well, coronavirus is incredibly unpredictable. People were going onto vents, and a lot of people were all of a sudden needing ventilator spaces. When the ICU had never seen their ventilator beds be so used. So one of the first things they had to do was try and make space. So what they then did was they had to basically cancel a lot of routine procedures, so operations clinics and things, move the staff from those places into areas of need, so into places like ICU, high dependency wards and things like that. And that naturally created quite a backlog. So there were people that were waiting for these procedures that were either becoming more sick and then presented as emergencies, or were unhappy generally because they weren't being seen to. Similarly, a lot of people became really scared in the first wave. So in our kind of first wave, which was between March, so lockdown started towards the end of March, and it went on for 3 months. So in that first period, a lot of people became really scared, and they just didn't want to come and approach anybody. So there's some like really kind of extravagant figures, like 60% less cancer referrals were done. So it's not like there wasn't any more cancer, cancer hadn't gone away. Cancer was definitely still there. And then we were finding people were presenting later. And obviously the consequences of that is when they are eventually seen by the cancer services, there's potentially less treatment that can be done for them. Equally, there were people sat at home with like heart attacks and strokes that were just not wanting to seek help and wanted some kind of a pill to fix the problem. And it was like, look, I know you're scared of coronavirus, but actually you could die of this problem. Coronavirus is being managed really well in our hospitals. So, please seek help, because even if, God forbid, you got coronavirus, you might be okay, but you might die from the heart attack you've got. So we were having a lot of really, really difficult conversations. The main effect of coronavirus I saw across the, you can say, NHS kind of social care system was, it was really sad. We basically heard of nursing homes essentially being wiped. So, patients were literally dropping like fleas. As soon as there was a spread or a breakout in one of the nursing homes, you would guarantee floors of patients were dying. And that's really traumatic for the people that are working there, but also for the people, for the families of these people. At the end of the day, we talk about deaths as numbers, but they're actually people, they're part of a family. And equally, family members aren't able to grieve like they normally would. So, where people would be able to gather, support each other. We've got limits on funerals here. In the first wave, people weren't really allowed to have funerals apart from like literally a handful of people, or it was done remotely. So it was a really difficult time. The NHS also, the government set up these Nightingale hospitals, which the idea was is they were like build up hospitals. So as soon as the hospital started to get really full, then anyone who wasn't really, really sick, but also still needed to have treatment, would be moved to these Nightingale hospitals. And these were all made regionally. So there was a handful made around the country. Thankfully, they've not really had to be used. So it means whatever measures that they took to try and manage the outbreak in the best way that they could was being managed. Whether that will change now, because we've got a similar amount of deaths now as the first lockdown, but we don't have a lockdown now. So we have strict rules, but there is still a lot of mixing. Christmas is coming up, people are going out. In some areas, restaurants are open again. So I don't know how it's going to be. So yeah, the second part of the question, could you remind me that? Sorry.
Of course, and you touched on it a little bit. It was just kind of how you felt it was being handled well and what could be done better. But I feel like you covered that, unless there's anything else you wanted to add. Yeah,
to be honest, I don't think I know how else they could have handled it better, apart from maybe started a bit earlier. But then I think part of that's a political debate, which isn't really necessarily the remit for you guys.
Thank you for sharing. Can you talk about any interesting cases you've been a part of or cases that stuck with you to this day?
Okay. So there's loads of interesting cases. It's always difficult to try and gauge exactly which one, because obviously in family medicine we see everything. So the most memorable case for me would be at the start of the pandemic, so back in March, there was an elderly lady in a nursing home, and I knew her and I knew her family quite well, and her family were concerned because of some quite vague symptoms with her, but the patient herself was like, no, I'm fine, I'm all right, I'm okay, there's nothing wrong. But the family understandably were worried about like coronavirus. So I think 2 days later, so I did an assessment on the phone, she was fine on the phone. 2 or 3 days later, so over the weekend, they felt like she was struggling with her breathing, and they called the ambulance, and then she had to go into hospital. She actually improved a little bit, but she needed oxygen the whole time. And because she was quite frail and elderly, she wasn't someone who was going to be escalated. And then we found out that she passed away. So that one stuck with me. It's a I wouldn't say it's like a boring case, but I know there wasn't very much that I necessarily did as part of that. But the reason why I suppose that stuck with me is because it was like one of the first times where I really felt like this is real. And coronavirus is affecting people, and obviously the effect that it had on the family from the beginning, and then when she passed away as well, really made it real for me. And I think this kind of touches upon a little bit, like there was a question asked before about that patient-doctor relationship kind of thing. So this was a completely professional relationship, but I felt really sad because I knew her and I'd managed her with lots of other medical problems, and actually in my role as a GP, there wasn't really very much else I could have done for her. And that's sad, where you can't, as a doctor, you always start your career thinking you're going to fix everybody, and actually you can't fix everybody. And sometimes that's a hard pill to swallow. So that's probably like the most recently memorable case for me.
Thank you for sharing that with us. Another question that we had is, have you been involved in research? And can you talk a little bit about that if you have?
Good question. So I won't lie, I've never been the biggest fan of like lab research. It's just never something that's stimulated me. Although I see its value and its relevance, I think just it's never been of complete interest for me. But the research that I have been involved with a little bit is teaching. So because I have a qualification for kind of undergraduate medical education, so I do teach medical students at our local medical school, and I also do some training for students in where I work. So there was a little bit of research I did with that, which was basically to see how effective the use of technology was with teaching. So this is in the early days where we weren't really using much apart from PowerPoints. So using things like clickers to try and increase kind of interaction and things like that. So as you guys all know, I'm sure that there's loads of different types of research, and it's actually really easy to do bits of research that interest you. Like I always used to assume that lab research was the only type of research that there is, but there's so many other different types of research you can do, quality improvement activities like audits and things. So that kind of exercise that I did with the medical education was my kind of first official bit of research, but I've done lots of quality improvement things working in the general practice setting as well.
You can answer only if you're comfortable. How do you find ways to cope with a patient's death?
That's a really good question. And I think this is something that we should always talk about openly. So I think generally I've always managed to find a good way around it. Usually the first thing I would do, and I would encourage people to do, is have a debrief with someone that you trust. So that's just like an opportunity to vent how you feel. You know, if it's something that has really upset you, then talk to someone about it. And it might be that there's a particular reason why you're upset. So one of the common reasons why sometimes doctors get upset about a patient dying is because they feel like they could have done more. But when you know that there's no need beating yourself up about it, like you did everything that you could have done in that situation, and then that's really reassuring as well. But equally, like I've said, you know, we are all humans. You know, out of all the deaths that I hear about and I see, you know, there might be 100 and there's like one in between that really kind of gets me. So generally we develop quite good coping mechanisms with someone dying. So part of it as well is like we have quite a big aging population in our area. So, you know, one of the eventualities of everyone's life is we are all going to die. My role as a GP as well is to make sure that when someone is coming towards the end of their life, that they are comfortable. And I will try and make sure that, you know, that they've got all the things that they need, you know, they're comfortable in the environment they want to be in, around the people that they want to be, obviously COVID permitting, and they've got all the care that they need as well, kind of psychological and physical care as well. And that for me is always a really big part of reassurance that that death was kind, that death wasn't painful for that person. Obviously there will be shock deaths, so there will be people that were really well, and you would never have expected they would have died, and then you hear something, you know, awful, like even someone's killed themselves, and you know, that was somebody who you thought was completely walking and talking fine. But like I said, debriefs are really, really helpful. So it's just you sitting down with the colleague, you know, just really having an open, informal conversation, just trying to get to the bottom of kind of what your uncertainties are, why you feel uncomfortable about it. And generally after that conversation, people feel a lot better. Unfortunately, these debriefs don't happen very commonly. And, you know, when doctors are living with uncertainties and it's affecting their confidence, that can eventually lead to like kind of ill health in themselves. So if not, they're not dealing with their own anxieties, they can start to become ill. And obviously there's a risk that that can affect patient care as well. So I've always been a firm believer from the beginning, just try and, you know, sort out whatever's in your mind, and hopefully it won't affect you going on in the future.
Then thank you for sharing that. And it's a really good topic to like bring up and like talk about. The next question that we have in the chat is, how do you help a patient who might not listen to the medical advice that you give them and are adamant about their own beliefs? I mean, like the research that they did prior to coming to you.
So that's a tricky one. It's a very common scenario though. So you'll have someone who's come in, read some newspaper article about some new drug and it's meant to like cure cancer or something, and they want you to prescribe that drug. And, you know, often it's about kind of exploring why they think, you know, this is the right thing to do. What do they understand about it? You know, what are they expecting me to do? Do they think that I'm just going to kind of listen to them and, you know, do what they want me to do? Or do they want me to give them just advice? You know, is this like a silly article, or, you know, go through that with them? And I think if you approach it in like a kind of a diplomatic way, so you don't kind of laugh at them, go, oh my God, what the hell have you just done? You just brought this to me, like, what on earth is this? You know, and if you kind of approach them sensitively, because it's probably taken them a bit of courage to think I'm going to go talk to the doctor about this. I've always found if you approach them sensitively and then you again sensitively explain, so, you know, this is really cool that this drug is out, but actually we don't know any information about it. You know, there's no research on it. It's being looked into. So far, the data shows us this. And, you know, it actually isn't something that I'm, you know, allowed to prescribe, unfortunately. However, you know, for this particular problem, these are the things that are licensed to be prescribed. And, you know, those were the things that I would recommend, because I actually know something about those things where I don't know anything about that. Often when you explain the kind of safety risk benefit thing to them, they don't tend to have any debates with you. They tend to understand it and accept it. And there will be the odd time where they just won't agree with what you say, but equally they won't be able to insist you either, because if you're very firm and you say, look, you know, that's my signature on the paper and I don't feel comfortable doing that, they might then decide to go and speak to another doctor, or sometimes they even become quite grumpy and they complain. But I think if you've always given factual medical advice, and safe medical advice, you know, by all means, if you want to get a second opinion from another colleague, just to make sure that would be what they would do as well, then fine. But there will always be some patients that will, their own health beliefs will always be more superior to your beliefs. And as difficult as it is, that's sometimes just something that we have to accept. You know, some people like to live a lifestyle, even if they know that there is harm in that lifestyle. You know, they're adults, they have mental capacity, they can make those decisions that they want, as long as they're aware of the harms. You know, there's nothing for us to do. We can't force to treat. Equally, we can't force them. We can't force them to be treated how they want to be treated.
Thank you so much. And you had kind of talked about this earlier, in that you get all types of cases as a general practitioner. But a question that we had is, what are some of the most common complaints and problems that patients come to you with? If you can just think of any on the top of your head.
Yeah, so there's plenty of common cases. Again, this all depends on what time of the year it is. So right now it's like winter here, so it's quite cold. Obviously coronavirus is around, so right now, you know, most of the symptoms people will talk to us about are sore throat, kind of flu-like symptoms, cold-like symptoms, infections, so like urine infections, chest infections, ear infections, and also dry skin. So people forget that when, you know, it's winter and the central heating is on, and, you know, they're not drinking enough water, that their skin will become dry. So a lot of rash complaints as well. That tends to be the most common. Yeah.
Thank you for that. Someone dropped in the chat, what role do you play in women's health?
Good question. So just trying to think how to answer that one. So with women's health, I guess I suppose an advocate, because I'm a woman myself and I know about women's health as well, but just very much like a doctor role. So, you know, patient has a problem that affects anything to do with women. So whether that's related to kind of bleeding problems or symptoms in the genital area, or breast problems, or mental health around, for example, pregnancy, when they've delivered, if they've had a baby loss, if they've had miscarriage, you know, people that might present with cancer symptoms related to women's health areas, so breast cancer, vaginal cancer, uterine cancer, ovarian cancer, all of these sorts of things. So I guess my role is just to kind of be an advocate, be able to give sound medical advice, and obviously refer onwards to a specialist if it's not something that I can manage, but I think, you know, needs to be seen.
Thank you so much. And you had talked about, you know, the common cases that you get in the winter, and a question we just got is, what are some common cases that you see in the summer?
So in the summer, common cases that we get, again, rashes is a common thing all year round, but the rashes we see are very different in the summer. So they tend to be things like bites. You know, people spend a lot of time in their garden, so they might have a reaction to something. What else? We get a lot of kind of allergy complaints. So they think it's like symptoms of a cold, but actually it's like an allergy, or they might be coming out in like a blotchy rash, which is related to an allergy. Joint problems are actually better. Joint problems are worse in the winter from generally what I see. And that's it. We see a few weird and wonderful things, but they tend not to be as common. Generally, like my clinic is always a little bit quieter in the summer than it is in the winter time, because I think people are generally quite well, so they don't really have as many problems. And because the weather is better, than, I don't know if this is seasonal affective disorder, but again, there tends to be less depressed people in the summer as well.
Thank you. You briefly went over it, but someone in the chat asked, did seeing neurology drive you towards family medicine?
I can't say. So when I think when I look back in hindsight, like now my experience, now neurology was quite helpful for me about the whole managing people that are dying and everything like that. But at the time it didn't. It actually pushed me even more away from family medicine, because I knew family medicine involved like managing dying people and stuff, but that's why it kind of pushed me more towards a speciality where there weren't as many people dying.
Thank you so much. Another question that we had was, what is the name of the medical school you attended? And if you're comfortable answering, do you remember what the average GPA was during the time of your application process?
So I don't think we have GPA, so I wouldn't know how to convert that, but I went to the University of Liverpool.
Thank you. The next question that we have in the chat is, what kinds of experiences would you recommend for students during this time when it's difficult to do things in person?
That's a really good question. So it's really good that, for example, there's organizations like yourself that are trying to arrange these kind of sessions online, and even in the UK, to be honest, that's probably some of the best experiences that there are. Now, in my surgery this year, so we've never done it before. Again, it's the very first time it was done, but we actually set up like a work experience at the GP surgery for like 3 days. There was about 6 or 7 students, and they basically joined online. They met different people from my surgery, so different members of staff, learned about the jobs that they did, talked about a few patient cases. So then they at least got some exposure like that. So I would probably recommend something similar. I mean, if there are areas of interest that you guys have, either, like approach someone from that kind of clinic or hospital setting and say, look, I want to do some experience. Have you got anything virtual going on? There's so much on social media. There's so much information on there, so much experience. And obviously you guys have quite a good program coming up as well. So I probably encourage people to try and make the most of these opportunities. I remember when I was doing my shadowing, half the questions that I get asked by students, I would never have been able to ask that to a doctor ever. That was all stuff that I discovered after I started medical school. So, I think the virtual world has actually made everything a little bit more accessible. It's just about accessing it from the right places.
Thank you so much. Another question that we had is, do you recommend partaking in medical internships or pre-medical internships?
So could you explain that kind of loosely, because I think it works a little bit differently here, possibly.
So I'm not entirely sure if the student who asked that question, they could put in the chat so we could further explain, but you could just go over from your perspective.
Okay. So I found it was really helpful to do work experience before I went into medical school. I know over there you have like pre-med and you have the stage before pre-med. So I think if you want to have an idea early on, definitely try and get experiences, sooner rather than later, because if that's going to change the career decision that you make, then you want to do that sooner rather than, you don't want to do it in your pre-med years and then realize, oh my God, I've just done pre-med, what am I going to do now? So, try and get exposure early, but continue to have exposure as well, because I think that always looks good. So say, for example, you're dead set on a career like medicine or nursing or something, and you had some experience from way back and you show kind of continuing experience with that, that makes the other person think, wow, they actually really want to do that career, like so much that they're actually, doing it on a regular basis, and they're trying to kind of learn about it and kind of develop on it as well. And it just means that when you get to that position, so when you become a medical student, dental student, whatever, that you have so much of a better understanding because you've been there long enough, obviously COVID permitting and things like that.
Thank you. You mentioned that you started your Instagram page during the pandemic. Where you share your like poems and like life stories? I've like read some of them. Why did you start your Instagram page, and why did you use more than a doctor as your caption or your bio?
So I started, the initial reason why I started the page was I was just fed up of seeing all these WhatsApp messages with misinformation about coronavirus. And I didn't really feel like that there was very much accurate information being spread on social media. So I think, and I've always been a firm believer that I think people from all professions should have a space on social media, just like people who spread misinformation do as well. It's free speech, free space, so why not use that kind of in a healthy and constructive way? Also during the first lockdown, life suddenly became quite quiet. So we didn't have all the social commitments and things like that. So I actually had a little bit more time. My caption has only recently just changed, to be honest. I was always thinking, okay, what would be a good caption that would describe me? And then I realized actually I am a doctor, and there is a lot of medicine on my page, but I feel like my life isn't just medicine. And that's why I share the other interests that I have. So, when I was in school, it's a bit nerdy, but I used to really like writing poetry. It was a bit like journaling for me, so it was quite therapeutic. I the school that I went to, I was bullied for wanting to be a doctor, but I never really felt like I had an avenue to be able to kind of express myself. And so what I did was I wrote. So I used to write poetry, and it kind of went from poetry to a bit of music. And so I used to spend a lot of time doing that kind of thing. And I felt like through medical school, I just lost it, like, because I didn't have the time for it. And then recently there was a few, like at the start of the pandemic, and there was a few things in the UK going on where they were trying to raise money for the NHS charities. And I was like, I've not written a poem in years, but I'm gonna give it a go. And then it got published in a book, which was awesome, because that just came out of the blue. And yeah, I mean, like, my life is my family, my life is my interests. Medicine is part of my life as well, but it isn't the only thing that defines me. So it's been an interesting journey, and again, it's just trying to get out there. Like, a doctor's life is like a normal person's life as well. The only difference is I work as a doctor, but that's my job.
Thank you so much for sharing that with us. Another question that we have is, what do you suggest that students do to make their resumes stand out to medical schools?
So it'll be difficult for me to comment on medical schools in the US. I can talk about it from a UK perspective. But the main things that stand students out in comparison to other students is genuine enthusiasm and a genuine understanding of kind of what they're getting themselves into. So the way that students should be able to try and include that in their kind of personal statements or resumes would be, when you've been on work experiences, or whenever you've done any work experiences, what was it that you learned from that makes you, I don't know, want to be a doctor, or you think you'll become a better doctor because of that experience. It's very common, like one of the biggest mistakes a lot of students do in their personal statements is just list out what they've done. So they assume, I've seen some really complex heart surgery and I saw how the surgeon was doing this and the nurse was doing this and the ODP was doing this. And like, no one really cares about the exact details of that experience. What they want to know is what you got out of it. Why was that a worthwhile experience for you tomorrow as a medical student and tomorrow as a doctor? You can talk about soft skills, you can talk about recognizing your own limits, you can talk about team working, you can talk about all sorts of other things. But it's kind of what you take from whatever experience it is. There's some students here that are unfortunate and they don't get much work experience, but they work, I don't know, at the equivalent of your Walmart. But they still find experiences that they can relate to. How, what has made them become what do they think will make them a better student or a doctor because of that experience there. So it's being you do have to sit down and really think about what experiences you've had, what you learned from them, what do you think would make you a better doctor, about yourself as well. Like, they want to know again that you aren't just going to be like a bookworm, that there is more to you. What else can you offer the world apart from the fact that you're very smart? They want to see someone who's like really well-rounded, likes things in the world, and isn't just like a science nerd sort of thing. So that's it really. Obviously there's all the other things that you have to tick the boxes, the grades and the references and things like that, but generally that's the advice that I would usually give to students over here anyway.
Thank you. Also, only answer if you're comfortable, but someone in the chat dropped, what's your thoughts on euthanasia or patients wanting to end their life?
So euthanasia is a very common ethical dilemma, but thankfully it's not a common dilemma here because it's illegal. So here it's illegal, and I think it's a good thing that it's illegal. I know people will go off to places like Switzerland. I think it's Switzerland where Dignitas is. That's the common ethical scenario where they'd go across over there because it's allowed over there. it's a very difficult thing for me to be comfortable with. So that's generally my opinion on it, but it's a legal standing in this country as well. So yeah.
Thank you so much for touching on that. Another question that we got is, given that Britain is the first Western country to launch a coronavirus vaccination program, do you have any hopes or concerns regarding this?
Good question. So I'm incredibly hopeful, and suddenly the country has become so much happier now, and a little bit of hope and optimism there that we might be able to get some kind of glimpse of normality back. So far it's been, today's the first day that people have started to be vaccinated, and I think people are all quite excited. Obviously from it's being delivered through the general practices in the country mainly, and the first people that are being vaccinated are the kind of frail and elderly people in care homes and people that work in those care homes. I think my apprehensions, to be honest, are just honest apprehensions, just like everybody else. So, it's a brand new vaccine that's been developed pretty quickly, which is how amazing science is, that they've been able to develop a vaccine so quickly and using technology that's so unique. Like no vaccine has been made using this kind of technology as far as I'm aware. So there are some natural apprehensions. What is the long-term safety profile? Will there be any long-term safety issues? I mean, so far, with most vaccinations, I don't recall any at the moment. So I'm hoping they've obviously gone through all of their safety stuff and that this will be fine as well. I suppose my only slight concerns at the moment is there's a lot of apprehension from different groups of people because it's not suitable for some people. So we can't give this vaccine to anyone under the age of 16. We can't give this vaccine to anyone who's pregnant, who's breastfeeding. And you can't try to conceive for a baby till at least 2 months after you've had the vaccine. So that excludes a big group of people. And these people were actually people that really would have quite liked to have the vaccine. So I'm hoping as the vaccine gets rolled out and more information is available, that it will just become a lot more open for everybody and people don't feel like they're limited on that they feel like they're left out and they've not had the vaccine and things like that. But equally just want to make sure it's safe as well, which we'll find out more with time.
You briefly talked about it when I asked you about Instagram. There's a lot of misinformation coming around. What can we do to stop that or spread actual information to people?
So it's really tricky because it's not always kind of small accounts or just kind of word of mouth spread of information. Sometimes there's really influential people, including the media or people that are quite famous, influencers, etc., that spread misinformation. So it's really challenging. I mean, if you see misinformation on social media or you see any information, you think, okay, what is the credibility with this? I would just suggest that you do your own research. So maybe read about it. And also you need to kind of know where to read this information from. So there are actual places, I think, do you guys use PubMed and stuff for journal searches and things like that? There'll be, I think you'll have your own kind of searching things. Yeah, love PubMed, cool. So, even if you did a quick search through there about, with some of the keywords, find out what research papers exist. And if you just read the abstract, which is usually in the kind of, it's very briefly summarized, or there will sometimes be summaries of that information somewhere on a reputable website. I would take that information as opposed to the information that you're reading. And if you're actually really confused, if say, for example, someone says, if you eat this causes cancer, or this causes this, or whatever, if there is someone trustworthy that like, for example, your own doctor, or say you've got a tutor who's studied these particular subjects, try and get, all I'd say is try and get information from the correct resources. So always cross-check the information that you're seeing. If you know 100% that this information that you're seeing is incorrect and it's misinformation, this is the hardest part. So you can either call it out, which can be in different forms. So you can either publicly do it, but that's quite risky because if you're, for example, talking, there's a post from an anti-vax account and you're pro-vaccinations, it just becomes really ethical, and sometimes that's better to avoid. But for example, you know, you can report posts, you can always add a reference link of correct information where you think, actually, I know you said this, but you know, why don't you think of this? Because I think this is information that's worth you knowing about. When it's kind of within family and friend settings, it's a lot more informal and it's a lot easier for you to sort of be like, oh, okay, so, you know, I know you said that, but, you know, why do you think that? You know, have you thought about reading into it a bit more? Because sometimes there's a lot of dodgy information and, you know, it's not always factually correct, and, you know, signpost them to maybe where they can actually get that information from. And they'll thank you for it as well, because they know no one wants to believe rubbish. People want to believe correct stuff. So that's probably the approach that I would say. I feel like sometimes I'm in a slightly better position to be able to call things out because I'm a doctor, but that doesn't mean that I always have the knowledge to be able to call things out as well. So I still need to know where I get my information from and where I cross-reference things, and obviously use my platform positively and spread actual correct health awareness and information as well.
Thank you so much for this talk. Do you have any last minute advice to pre-med students and pre-health students in general?
The only bit of advice I would give is just make sure you know what you're getting yourself into. So I have absolutely no regrets becoming a doctor, but the only regret I have is I never really considered any other careers. I considered them after I became a doctor, which is obviously the reversal. But then I still kind of realized that what I'm doing is what I want to do. But use the opportunity that you have just to like talk to different people, meet different people, you know, get to know different professions and other things that you might be interested in doing. One of the best tips I've ever been given is by doing a personality questionnaire, like a career personality questionnaire. So, you know, they ask you loads and loads of questions about you, and at the end you get all of these kind of personality trait kind of recommendations, and sometimes that can lead you into what kind of career would be more suitable for you depending on what your personality is like. That's not to say they're always correct suggestions, but that's sometimes a good way to start. And yeah, enjoy the time while you're trying to find that information as well.
Thank you so much, Dr. Khan. It was an absolute honor to be able to host you today with pre-health shadowing. For all of my students, I will go over how to take the post-shadowing assessment at the end of this, so please stick around if you are interested in doing that. My first announcement is this is a different QR code. This is actually to join the fundraising team rather than to donate. So we welcome you guys all, if you are unable to financially support us at this time, to join our fundraising team and help us send out requests and share our message and share our program with others so that they can help us keep pre-health shadowing alive. If you do join our fundraising team and begin sharing, you can actually get verifiable virtual volunteer hours for this, and I will explain further how to do so. So next announcement is we welcome you to join our student team. This is a 100% remote opportunity. It gives you the chance to meet with like-minded students, people who are interested in going into the health field. There are leadership opportunities available, and it really does allow you to get insight into what the professional world is like. You get professional experience, you get opportunity to work on projects that look great on your applications. And so if you are interested, you can apply either by scanning this QR code that will take you directly to our website, or you can find this on our website under the Contact tab. If you feel as though you do not have enough time to commit to pre-health shadowing, that is more than okay. We also have volunteer opportunities available, which allow you to work from home for as many or as little hours as you want. If the only time you have available is 2 in the morning, you can volunteer your time at 2 in the morning. And so if you guys are interested in doing this, we welcome you to sign up to become a volunteer. This is also available on our website under the Contact tab. Stay updated with the shadowing sessions. We post all of our shadowing sessions on our official Instagram page at Pre-Health Shadowing. I have a challenge for you all today, and that is to go to our Instagram page and find Dr. Khan's Instagram post. If you are able to successfully comment her last name letter by letter on the post, you will be entered into the opportunity to win the student of this session. So this is really difficult because of the way that Instagram has updated their algorithm. Good luck with this. It's very difficult, so you guys got this. Another reminder is to tag us in your post for an opportunity to be posted on the official Pre-Health Shadowing account. You can tag us on TikTok, Instagram, Facebook, and Twitter. So just be sure that you guys are helping share. This is a great program for students. It's very accessible, and it's one of the few ways to get shadowing or clinical hours during the pandemic. And so be sure to share this so that anybody who is interested has the opportunity to join. Our next shadowing session is tomorrow at 5:30, that should say p.m. Pacific Standard Time. And to take the certificate quiz, you will first go to our website, www.prehealthshadowing.com. You will then have to find Dr. Khan's profile page in the courses. So you will have to search all courses until you find Dr. Khan's page. To the right of her picture, you will see take this course. You will have 30 minutes to complete the assessment and 2 tries. If you pass the assessment on the first time, I encourage you to download your certificate immediately before trying again. Once you pass with a 70% or higher, you must return to the speakers page and click Finish Course. This is a crucial step. If you do not click Finish Course, you will not receive your certificate. So please be sure that you guys are clicking this button. Once you do that, your certificate will appear and you should be able to download it immediately. You can also find your certificate at any time in your profile under the Certificates tab. If you guys have any questions or issues with this, go ahead and email us at info@prehealthshadowing.com and we will get back to you. Thank you all for joining us today for our virtual shadowing session. This concludes our session for today, and I invite you all to disconnect from the call. Thank you.